All right. Nope, that's great. And then I can just advance it. Okay. Okay. Okay.
All right, everyone, I'm going to hand it over to Kathy.
All right. You guys can calm down, and my nerves are kind of way up there right now. So I want to thank Professor Klinke Borgman for letting me teach today. I have worked on, can you hear me? Okay. I have worked on the oncology bone marrow transplant unit for a couple of years. So although I am no expert in cancer, I do have a little bit of clinical background in that area. And so when we were talking about topics for this semester and what I could teach when I saw the cancer unit, I was very excited that I would be able to do that. So I ask that you be patient with me today, because although I have taught in maybe smaller settings, never 104 students at one time. So anyway, I have to actually record this. If just teaching wasn't making me nervous enough, I have to record it to send to my professor. So everybody say hello to Dr. Sims-Giddens. Can you tell her hello? Okay. That way she knows how many are in here.
You really were talking to 104. You weren't
Yeah, I really was. I really was. All right, I'm going to kind of push that out of my way a little bit. Hopefully she'll be able to see me. Okay, so we're going to talk about the biology, clinical manifestations, and treatment of cancer today. How many of you have had someone close to you, whether a family member or a friend, affected by cancer? Almost everybody in here. So it is a topic that is close to everybody's heart. I will say that working on a cancer unit, a lot of people think, oh my gosh, how depressing would that be, working on a cancer unit? It's actually almost the opposite. Cancer patients are unlike any other patient. They, and I've told them before, they have taught me so much. They've taught me what's really important in life. Because little things don't bother people that are fighting for their life. You learn what's important, and things that I thought were problems before really are not problems. Even teaching this, not that big. Okay, so there are your objectives for today. So let's talk about terminology. So tumor. Used to, a tumor was pretty much referred to as just any swelling caused by inflammation. It's also now referred to as any new growth or neoplasm, which neoplasm is just a new and abnormal tissue growth. Benign tumors, there are two different types of tumors, benign and cancerous. Benign are non-malignant tumors, and of course cancer is a malignant tumor. Benign tumors are not going to kill anybody, but they can cause symptoms depending upon where they're at. If there is a benign tumor, say at the base of somebody's brainstem, then they're still going to have some neurological effects from that. So although it won't kill anybody, it can actually cause some symptoms. Okay, so let's talk about what characteristics make up a benign tumor. A benign tumor is well differentiated, and when I say well differentiated, I mean that it looks very similar to the tissue that it originates from. So it just looks the same as that almost. So it's easy to tell where that tumor came from. There also has a well-organized stroma, and what I'm talking about like that, it's what holds that tumor together. It's kind of like the infrastructure of a building that holds it together and keeps it in place. That's the stroma. It's a well-organized stroma in there. It does not invade beyond its capsule. It has a capsule that encapsulates it, and it doesn't grow beyond that. And it's named according to the tissue is originated from and ends in oma, O-M-A. So if you'll see that top picture up there, that is a picture of a hemangioma, which a hemangioma is just a collection of red blood cells, and you've probably heard it referred to as a birthmark. And I'm sure you have seen multiple of those, but it is actually called a hemangioma. A lipoma is just a collection of fatty tissue, and that is the most common benign tumor in adults. A lot of people have had them. My husband had one, so yeah, they're very, very common. All right, so malignant tumors. How are they different than benign tumors? Malignant tumors have rapid cell growth. They lose cellular differentiation, also called anaplasia. You might want to remember that. So they have a loss of cellular differentiation. And by that, I mean, when we talked about the benign tumor that had it was well differentiated and it looked like the tissue it came from, a cancerous tumor loses that look of the tissue it originated from. So if that tumor spreads to a distant part of the body through metastasis, sometimes it can be very difficult or almost impossible to determine where that originated from. And we need to know where it originated from to be able to treat it. So very important. Has an absence of normal tissue organization. It's pleomorphic, which means it can come in a variety of shapes and sizes. It has a large amount of disorganized stroma. It has no capsule. It's invasive. And when I think of a large amount of disorganized stroma, I think of that, when people are on an airplane and there's a large man sitting next to you, they call it the man spread. They kind of take up all the room. That's kind of what I think about with malignant tumors, because they don't care who's around it. They're going to just keep going, and they push everybody else out of the way. So that's kind of what I think about with that. And the most deadly characteristic of malignant tumors are metastasis. And by metastasis, we mean that it can travel through blood vessels and through the lymphatic system to far-reaching parts of the body. It can go to surrounding areas, so it can go just next door and start planting more tumors, but it can also travel through those blood vessels and through the lymphatic system and start a tumor in a totally different area of the body. Malignant tumors are named by their cell type of origination. So if it arises from the epithelium, it's a carcinoma. So of course your epithelium is like your skin. If it arises from ductal or glandular tissues, it's adenocarcinoma. Connective tissue, your skeletal muscles, something like that, that is a sarcoma. If it arises from your lymphatic system, that is lymphoma. And if it arises from your blood-making cells, that is leukemia. And probably the ones that I have the most experience with are lymphomas and leukemias. So let's talk real quick, just focus on the differences between a benign and malignant tumor. So we said a benign tumor is slow-growing, a malignant tumor is fast-growing. A benign tumor is well differentiated. It looks like the tissue that it originated from. A malignant tumor is poorly differentiated. It does not look like the tissue it originated from, and sometimes very difficult to find out where it did originate from. Benign tumors are non-invasive. Malignant tumors are very invasive. Benign tumors do not metastasize. Malignant tumors metastasize and can go to different parts of the body. Okay, cancer in situ. This is just a little bit different. It is not actually a cancer at the point when it's first noticed. It has incremental development, so it slowly builds on itself. It's an abnormal growth in the epithelium, but it doesn't invade the stroma. So there's 3 possible outcomes to cancer in situ. It can stay the same for a very long period of time. So it doesn't grow, it doesn't do anything, it just stays there. It can actually regress and go away. I would say that's probably not the most common, but it can regress and go away. Or it can progress and become an invasive cancer. Normally, if somebody is diagnosed with one of these, they're going to probably go ahead and have it taken off. Because right now, there are no statistics on how many of these will regress and go away, how many will stay stable, and how many are going to progress and become a cancer. So most people will opt to have it taken off. My son-in-law actually, just a couple of weeks ago, he found out his aunt had had a cancer in situ for a long time, had it checked regularly, and had opted not to have it taken off, and just found out it has progressed to malignant melanoma, and very few options for her at this point. So always better to have it taken off. Okay, classification of tumors. So tumors, we base the treatment on, used to be just their microscopic appearance. They'd look at a piece of that tissue under a microscope and base their treatment on that. Now we can do immunohistochemical analysis. That's kind of a big word, I know. But what they're doing in that, and also molecular analysis, they're looking at the cells of those tumors for any antigen and antibody interactions that's going on. And that probably sounds kind of boring and like, so what, big deal. But it really is a very big deal. When we can find more about what is making that cancer grow and work, then we can treat it. I know all of you have probably heard about chemotherapy. Well, there is also biotherapy, and I don't know if you have heard too much about biotherapy, but biotherapy is actually molecules that are created in the lab that we then can put in a person, and those molecules basically go to those cancer cells and put a big red light on it and says, immune system, come eat me. So it's a very different thing, but what it's doing is making your own immune system fight that cancer. So it's really interesting. And I will say, here at KU, we have we're just the most up-to-date on research trials. And it's an interesting place to work because we are constantly doing trials on the floor and seeing how these things work. Okay. All right. So tumor markers. Tumor markers can be released by a benign tumor or a cancerous tumor. Not all tumors are going to have tumor markers, but some do. They can be present in the tumor cell, in blood, in cerebral spinal fluid, even in urine. So these can include hormones, enzymes, genes, antigens, and antibodies. You might want to remember that too. So what tumor markers are enzymes, genes, antibodies, and hormones. Oops, is that going? Hold on, I've got to make sure this is still recording. Excuse me. It went blank. There we go. All right, it's recording again. And hopefully it didn't get rid of the old one. Oh, well, if it did, it did. I can't help it. Okay, so tumor markers, we talked about those. So let's go on. So there are 3 ways to use a tumor marker. We can use it to screen individuals. So a lot of you have probably heard about when men get to be about 50, they check them for prostate cancer. And one way they check them for prostate cancer is through screenings. If screening can be a physical exam, or it can actually be something like a blood test. And a blood test is going to check for a PSA level. So if somebody, if they think someone may have prostate cancer, they'll look at that blood level, and if that PSA is elevated, it's going to tell them the likelihood that they have prostate cancer is very good. They never diagnose just on a tumor marker, but it does give them somewhere to start and to look at, to see if that person may have it. All right, so the biology of cancer. So cancer cells are abnormal cells that divide without control. They invade all the surrounding tissue. Like we said, we were talking about like the guy on the airplane. They just invade everything around them. They are created from normal cells, but they become activated, and we're going to talk about that in a minute, how they become activated. They lack contact inhibition. What we say, they just push out everything around. They don't care where they're at. They just keep multiplying and push everybody else out of the way. And that is one of the things that causes symptoms in an individual, is when those cancer cells grow and they're pushing on other things, it can cause nerve pain and obstructions, a lot of different things. They are anchorage independent, meaning they don't have to be attached to something to grow. They can just grow. And they are immortal. They can live forever. There's nothing stopping them. They actually have a sample of cervical cancer in a lab that was taken in 1951. Those cancer cells are still dividing and replicating in that lab since 1951. So that's what I say. They are immortal. They do not die. Genetics of cancer. So cancer cells happen through a couple of different things. They accumulate through small changes to DNA. They are called a disease of aging, and they come through DNA mutations. So let's talk about it real quick. DNA mutations happen, there are hits on your DNA. They just hits on your DNA. And the older you get, the more hits are going to happen to your DNA. So let me see if I've got this picture here. We'll go back to it in a minute. If you can look here on that, it looks like really up until about the age 45, there's really not a huge risk for cancer on there. But once you hit 55, those risks start going up. And for men, by the time they're 75, their risk for developing some type of cancer are huge. So that's why we say that cancer is a disease of the aging, because the older you get, the more hits happen on that DNA and can cause cancer. So then, let's see. Also, clonal proliferation and clonal expansion. I don't think I'm going to talk about that too much. So let's talk about oncogenes. This is one of my favorite parts. So we have proto-oncogenes. Proto-oncogenes are not cancerous. They are just, they're in the cell. So there's a proto-oncogene. It's a normal, non-mutant gene. It's not a Ninja Turtle. So then they have the mutation of the proto-oncogene, and it becomes a bad gene. And it becomes an oncogene with the potential to cause cancer. It doesn't cause cancer just on its own, but when that is activated, when that oncogene is activated, you're going to have the high likelihood of developing cancer. So activated oncogenes are cells that were designated for apoptosis. Who knows what apoptosis is? Anybody? Programmed cell death. Yeah, that's what apoptosis is. So oncogenes are cells. They were designated to die, but then all of a sudden, these oncogenes say, oh, I don't think so, and they go on and live. Okay, and I will go back real quick. So when I think of an oncogene, who watches NASCAR? Anybody? Try to make sure. No? Okay. Well, anyway, they were in Kansas this weekend. I don't really care for it either, but my husband's a big NASCAR fan. But when I think of an oncogene, I think of a race car with that gas pedal stuck to the floorboard, and you can't get your foot off of it. And it's going full steam ahead into cancer. So cancer is that far off wall, and that car has got that gas pedal to the floor, headed for cancer. Then we have tumor suppressor genes. Tumor suppressor genes, in their normal state, encode proteins to stop or halt proliferation. So it's what tells cells, okay, it's time for you to die. You've gone long enough, or you need to slow your growth, or you need to stop it. They repair DNA mistakes. They signal cells for apoptosis, again, what we said was programmed cell death. So in order for cancer to develop, they have to be deactivated. And then that allows cells to grow out of control. And when I think about tumor suppressor cells, I think of that same car with a brake pedal that won't work. I can hit that brake pedal all I want, but it is not going to stop it. So I think my son's trying to get a hold of me. Okay, so for cancer to develop, it's important to know that both of these things have to happen. An oncogene has to be activated, and a tumor suppressor cell has to be deactivated. So the oncogene is going to cause things to grow rapidly, and the tumor suppressor cell is going to let that happen. All right. There we go. All right, there's my little picture down there. You can see the race car that's not working. And again, like we said, oncogenes cause cancer when they're activated. Tumor suppressor cells cause cancer when they are deactivated. It takes both things to happen. And those things happen by hits on your DNA. So that's what happens. Those hits on the DNA allow that oncogene to become activated and that tumor suppressor cell to become deactivated.
Kathy, what kind of things would cause a hit on the DNA? So what do you mean by that?
I think, let me see if I got it here. So hits on DNA are going to come from a couple of things. A hit on the DNA, it can come from chemicals, radiation. That can cause a hit on your your aging. And you asked me, and I had it written down. But there are three things actually that cause that to happen, and one of them is chemicals. And right at the moment, I can't think.
Well, I just wanted to sort of bring up the point that oftentimes the hit on the DNA would literally just be like the carcinogens that we're sort of,
exposed to every day.
Yeah.
Mm-hmm.
So just things in the environment that over time can
Right.
accumulate on our DNA. That's all.
And the thing is, it takes specific hits. So our DNA gets hit all the time. And we have little cells that go in and try to fix those all the time. It takes specific hits for cancer to develop. So not just, and like she said, chemicals especially. And I know you've all probably heard of people that maybe have been around asbestos, something like that has then caused cancer later on. Okay, so small DNA changes. Small DNA changes are, okay, hopefully this will reach with me. Small DNA changes, if you have your DNA helix and you have So this is A, and this is T. They go together, and then you have G, and you have C. Okay? So a point mutation is going to be when A and T always go together, C and G always go together. So if these get switched around, and G is now mixed with T, and A is with C, that's a point mutation. Okay? That is a point mutation. And those can turn that normal oncogene into an activated oncogene. Large DNA changes are chromosome translocations. So a piece of one chromosome that should stay with that chromosome actually goes to another chromosome. And a specific example I can tell you is Burkitt's lymphoma. Burkitt's lymphoma, a piece of chromosome 8 goes over and attaches to chromosome 14, which it shouldn't. When that happens, it results in excessive cell proliferation, which actually causes Burkitt's lymphoma. And it is a cancer of maturing B cells. So another one is when two chromosomes become fused. And I really have had a hard time figuring out how to draw this one. But so your chromosome looks something like that. I'm not very good at drawing. So if you have two that are going to fuse in the middle, and so like I said, I really am not very good at drawing. Okay, so let's say that's two that are fused in the middle. When they fuse in the middle, it creates a protein called tyrosine kinase. And that protein then promotes myeloid cells to grow. And that is one way, and that's why I tell you, even though these things, you may think, well, what's the big deal about these? When we can look at these things, when they can discover this when they're looking at it through their immunohistochemical analysis or their molecular analysis, it's going to show them better how to treat it. If they can find out what exactly happened in the DNA to cause it, then they have a better chance of actually treating it. Hopefully this is still working. Okay. All right, this is just a picture of different types. So that is your normal DNA, and I don't know if you can see it very well, but T and A always match up, and G and C always match up. And then over here are your small DNA changes, your point mutations. You can see on the top, T and A are matched together, but then on the bottom, T is with C. So that's your point mutation, and then over on the side is the large DNA changes, where chromosome actually moves from where it should be to another chromosome. All right, and you guys are probably, we'll do this and then you can go on your break. So gene mutation, gene amplification, it's a duplication of a part of a chromosome that should just duplicate itself, once, but it just continually duplicates. So it could duplicate tens, hundreds of times. And then we have epigenetic silencing, which can silence a very large part of a gene. It can actually silence a whole gene. So that is what can cause those tumor suppressor cells to turn off. It's telling it to be quiet. We're not going to we're not going to listen to you. So it can actually turn that off, and it helps cancer cells develop a lot faster. The thing to remember about the epigenetic silencing is this is not a DNA mutation. It just is something that can happen. So, all right, we'll talk about that when you come back. So you guys can go on your break.
Can you go back to that last slide?
Yeah. Anybody have any questions so far? Okay.
Great. About 10 minutes and we'll start back up at 9. Sure. Yeah, let's go look at it.
silencing occurs? Is it in the same way that you get hits, since it doesn't actually require a mutation?
No, I mean, that is just one way that the tumor suppressor cell could be silenced. But no, it's silenced through a lot of those DNA hits on it.
Just lots of different things, and that's what that whole kind of cascade of changes that it has to require. Once you get so many weird changes, one of those changes will be silenced.
Exactly. Exactly. That's why the older you get, the more likely it is that it's going to cause cancer. Yeah.
Just understanding.
Yep. Yeah, I'm not the best person to draw. Kind of looks like a spider there, doesn't it? You're probably right.